And we are back. Heart disease is the leading cause of death for women in the United States, yet only half of the women recognize it as their number 1 health threat. A newly published landmark study in the New England Journal of Medicine sheds the light on the critical role three specific health markers play in predicting cardiovascular risk in women. Joining me now, we've got the founder and medical director of Cherry Creek Heart, Dr. Payal Kohli, and we thank you so much, Dr. Kohli, for being with us.
Thank you so much for having me, and what an important topic to discuss today.
It is an important topic to discuss, and when we talk about this cardiovascular risk to women, as we say, it's prevalent, but then yet and still so many are not aware. Is there any particular reason that we're seeing for a lack of awareness on the part of women?
You know, it's interesting. We've always thought about heart disease as an old man's disease, and what we really don't appreciate is that it's everybody's disease. In fact, statistically, it's the most likely thing to get any of us. And heart disease actually starts to happen in your 20s and 30s, but it's not really until your 60s and 70s that it manifests or declares itself. And I think that's one of the big reasons for this lack of awareness, because people don't understand that heart disease is happening as we age, and it's common, and it's something we need to address. And the other piece of this, I would say, is that cholesterol, which is the biggest driver of heart disease, and inflammation as well, aren't symptomatic always. So we don't always have symptoms from heart disease until obviously it declares itself or manifests itself. So it really behooves us to get ahead of the disease, to look, to check, to make sure we're getting our blood tests so that we're knowing what the disease is doing before it actually acts up.
Well, Dr. Kohli, I know that there are some recent discoveries that have been made in this particular area. So let's walk through a little bit about what are some of the recent discoveries that you've made.
You know, I've been really excited as a female cardiologist to see that now we're getting better at predicting heart disease. We're getting better at looking into the future and knowing who's going to go on to have a heart attack or stroke. Because in the past, like I said, we always waited for the event and then we did something. And we used to only just check your cholesterol. But this new study that just got published in the New England Journal of Medicine said it shouldn't just be the cholesterol, but we should check these 3 markers. And this is blood tests that are already available. So talk to your doctor about ordering them. One is the cholesterol, because cholesterol is the big driver of heart disease. Second, however, is inflammation, which we're now appreciating is a big driver of heart disease. And that's a test called CRP. It's a blood test. And then the third is a fat particle in your blood called lipoprotein A. Now, 20% of us are walking around with this number elevated, and it's mostly genetics, about 90% genetically determined. But what these markers do is they put target signs on you. I like to call them. These are big target signs. So if your markers are elevated even early in your life, and that's what the study showed, and women in their 40s and 50s who are healthy had elevated markers, 30 years later, they went on to have that heart attack or stroke. So those are the people that we would then treat more aggressively.
Reducing inflammation, very critical. So I think as you talk about inflammation, not something that maybe many people are going to think about, that inflammation really can be very critical to heart disease.
It can be, and we've just learned this ourselves as cardiologists, but inflammation evolved to protect us, right? We get a cut, we get inflammation, it heals the cut. But when inflammation turns on when it's not supposed to, or when it stays on, which is what happens in patients that have inflammation-driven heart disease, that's when it can be problematic. So we really need to start thinking about checking inflammation along with cholesterol and checking this other marker called lipoprotein A in almost everyone as a way to sort of get ahead of it and know when inflammation is misbehaving and becoming chronic and causing heart disease.
You know, in the beginning, I said at the top of the lead, I said that it is one of the leading causes of death for women. An astounding number of people are dying from heart disease, lack of awareness. Let's make the correlation here. Why are we seeing so many women suffer at the hands of heart disease? And how do you feel about the awareness game? Is it improving?
You know, I call it the gender gap. And unfortunately, this exists not just in how much women get paid or how many promotions they get, but even in their medical care. So women don't know that they have heart disease. Doctors don't diagnose heart disease aggressively enough in women. And then even after we diagnose it, women get undertreated. So it's a chronic problem. And the sad thing is women don't just have the traditional risk factors, the hypertension, the diabetes, the obesity, the high cholesterol, but they also have risk factors related to their pregnancy, related to when they went into menopause. These can all contribute to cardiovascular risk in women. So I think we have to do better as a system, but part of that is us as women who are used to being in charge and used to being in control, saying, I need to know my numbers so I can know my risk. So this is why I want every woman to feel empowered with this type of data, to get those numbers checked, to get ahead of heart disease, to be smarter than the disease by checking things that aren't declaring themselves yet, so that they can start to modify their risk, talk to their doctors, not just about lifestyle changes, which can reduce your risk with inflammation and with cholesterol, but even medications that could help to do so.
Are there anything that you can tell us with regards to blood tests? Because I know that that's the key to detection in a lot of ways. But the regularity, if you will, how many times a person should be tested? Is there a particular number that you're looking for annually?
Yeah, so the cholesterol panel should be annual. That's your lipid panel. You usually get that with your annual physical. You should get a hemoglobin A1C, which is a blood test that tells you about your blood sugar. You should talk to your doctor about a urine test called microalbumin. This is a test that starts to tell you your kidneys are misbehaving before you actually see the blood test, the kidney test in the blood get worse. So it's actually a smarter test than just looking at the blood test. So those are the three tests probably at least once a year. That lipoprotein A, which I talked about being a genetic marker, once in your lifetime. You don't need to keep checking it over and over again. But guess what? If you're that 20% that's elevated, I'm going to check your kids. I'm going to check your siblings. So it triggers what we call cascade family screening. So it's not just about your risk, it's about the risk of your loved ones if you get that check. But that's only a once in a lifetime test. And then the CRP, which is that inflammation marker, that can go up and down. So that we check at least twice to make sure that it's persistently elevated, because if I have allergies or I have a cold, it's going to go up. But you want to make sure that you're assessing inflammation that's chronic, that's kind of gone up and staying up. And so that test would need to be repeated. And then over time, as you introduce lifestyle measures to reduce that, you could check it again to see if it's come down. I would also encourage everyone over the age of 40 to get an X-ray of the heart called a calcium score. This is a 5-minute test, and it tells me if you already have calcium, which sticks to cholesterol in the blood vessels around your heart. And guess what? That's that target sign, and that's a big target sign if you already have plaque in your 40s.
Yeah. Dr. Kohli, as a female cardiologist, talk to me about, having this opportunity to really deal with women who are dealing with this number in an unfair advantage, if you will. We know that when it comes to heart health, women are really dealing with heart disease at an astronomical rate. But then to have female cardiologists, women cardiologists in the room discussing the research, talk to me about the effect of that and how that's actually, a positive thing in the world of the medical, in the medical world, I should say.
Well, with all the advances that we've had, especially in women, I feel like we have learned so much. So I feel very positive as a female cardiologist that, yes, women have more inflammation, so their markers are more likely to be up. Women have more side effects to statin medications, so it's less likely that they're going to get treated. But even despite all that, we're understanding so much more about pregnancy, about in vitro fertilization, about menopause, about all the things that happen to women and how we can use those things to assess their risk. In fact, if you get a mammogram in your 40s and you have tiny little what's called breast arterial calcifications, meaning little calcium deposits in the small arteries of the breast, that predicts your risk of having bigger arteries, like your heart arteries or your brain ones, have problems 10 or 20 years later. So I think we've gotten smarter about how to think about risk in women, and I'm really positive about that. I also think all the medicines that we have coming, a lot of them now are actually being studied more in women. So one of the problems had been that in clinical trials, you only have 1 out of 4 women, or maybe 1 out of 3 women. But now we've had clinical trials come out that have half women. And since half of the world's population is women, we really ought to be doing science and research that represents the world's population. And I would go on to add that that's true even when it comes to, underrepresented minority groups. There's so little that we know. Most of the studies that we have are in Caucasian populations, but it's really very important for us to think about your ethnicity when we think about your risk, because like I'm South Asian, my risk is higher because of being South Asian with respect to certain factors. So now we have risk calculators that include race as part of your risk calculation. They include your zip code. So it tells you where you're living and how much access you have to care, because we know that those types of social determinants of health are also really important when it comes to predicting risk. So I feel really optimistic about where we are in terms of how we can help our women and our underrepresented minorities and help to really bridge that gap.
Yeah, Dr. Payal Kohli, we got to leave it there, but great information, and certainly an awareness is out that an awareness for people on the risk of cardiovascular health in the lives of women. Thank you so much for joining us, Dr. Payal Kohli. She's the founder and medical director of Cherry Creek Heart, and she's been with us. Now, if you want more information, visit the website, cvdinflammation.com. We encourage you, don't go anywhere. We are coming back more open when we return right after this.